It's 8 p.m., so I'm going to start the introductions. Good evening, everyone. Welcome to the SOAP membership, to our speakers and faculty for today at our first SPEED event that Society of Pediatric Echo Education dates for 2023. And I really would like to thank Dr. Seda Tierney and John Lipinski for leading SOAP education subcommittee years, and want to throw a warm welcome to our new SOAP education subcommittee chairs. That's Neha Soni Patel and Jen Kobu. Jen Kobu is an associate professor at University of Florida, and she leads the fetal program and the single ventricle program, and an absolute phenomenal physician and person. And Neha Soni Patel, a dedicated educator, literally so much passion and energy, and can't think of like two better people to lead and take on the leadership for the SOAP education subcommittee. I also want to thank our institutional sponsors, that's Seattle Children's, Lucille Packard's Children's Hospital at Stanford, Nemours Children's Health, Cincinnati Children's, and Children's Hospital of Chicago for and I look forward to other institutions joining. So over to Sada and Arti.
Thanks, Shubi. I was wondering if Neha wanted to say a few words as well.
Thank you, Sada. Thank you, everyone, for joining us for our SPEED session today. My name's Neha, and Jen Kovu and I are the co-chairs of the Education Committee for this year. And we are very thankful to have all of you join us. We hope that you'll get a lot of information out of these short sessions. I want to quickly just say hello to everyone, and I'm going to hand it off to Dr. Seda Tierney from Stanford. And in addition to all of her activities, she's the QI Echo Lab Director, and Dr. Arti Bhatt from Seattle Children's Hospital, and she's the Director of Quality Improvement in the Heart Center at Seattle Children's Hospital. So we are very happy to have two experts in QI in the Pediatric Echo Labs with us. So Seda, take it away.
Thanks, Neha. SPEED is in great hands. It's going to be a great year. I'm excited to hear all the sessions coming up. Just some housekeeping rules. Please mute yourselves, and we'll have a Q&A session at the end. So keep your questions, or as you think about them, put them in the chat. We'll try to address all of them. Next, it is my distinct pleasure to introduce Allison Doucette from Texas Children's Hospital, where she's currently serving as a QI Quality Improvement Specialist and a Technical Director of the Pediatric Echo Lab. She will share with us her perspective on how to ensure quality in a Pediatric Echo Lab. Allison, please take it away.
Okay, good evening, everyone. I would like to thank the organizers for inviting me to speak here tonight. This is going to be an overview of the structure of the quality assurance program in our pediatric lab here at Texas Children's Hospital. My hope is that you will find this helpful for implementing a quality assurance program in your own lab. Okay, so when embarking on any project, we always want to ensure that it aligns with the goals of our institution and the domains of healthcare quality outlined by the Institute of Medicine. So these domains are patient safety, effectiveness, efficiency, patient-centered, timeliness, and equity. So some of our current projects are listed here, showing how each project aligns with one of our domains. And I'll be talking more in depth about the highlighted projects in this presentation.
Allison, we don't see your second slide. It's on the first slide.
Oh, I'm sorry. Sorry. So these are some of the projects that we're working on, and I'll be talking about the highlighted ones in this presentation. I apologize. So who does the work? So we all know that quality assurance takes a lot of time and effort, and so in our lab, we're actually lucky to have people with dedicated time to do this. We have a dedicated QI specialist, that's me, and I have approximately 50% of protected time. So I maintain the lab accreditation, and I'm responsible for reviewing and auditing studies. And we also have a sonographer educator who has 1 to 2 days of protected time a week, and she organizes education for the team, which ensures our high quality studies. And we also have teams made up of cardiology fellows and sonographers that help manage our data. Okay, so like many of you, we are accredited with the Intersocietal Accreditation Commission, and we've been with them for many years, and we all know what's involved in maintaining accreditation. So we complete our quarterly case reviews, and those components are listed here. And when I get the report back, I send it to the sonographer and the interpreting physician so they can see their individual feedback. And we are also, our diagnostic accuracy is very important, so we have a team that's actually dedicated to this, and I'll go over that process shortly. In addition to our quarterly reviews for accreditation, we also participate in ACPC reviews. As many of you are aware, the Adult Congenital and Pediatric Cardiology section of the American College of Cardiology has developed metrics that our labs can perform and report quarterly. And by participating in this, we're able to see how our institution is doing compared with other participating institutions. So we are currently reporting on comprehensive echo completeness and quality, as well as reporting on our diagnostic accuracy. So the ACPC developed checklists to assess study completeness and quality with specific criteria, and points are given for each criteria met. So our process for data collection is to have each sonographer select 2 to 3 studies for review. And the purpose of us doing it this way is to give the sonographer the opportunity for self-reflection by closely evaluating their own work. In addition to the ACPC metrics, I also assess our protocol adherence. We made some changes to our protocol last year, and we wanted to ensure that the team was adapting. So like the ACPC checklist, points are given for each of the criteria met. And with this auditing system, we're able to see how we're doing over time. We calculate the average for the group and track individual progress. Our sonographers receive their individual feedback, and auditing has helped us see an improvement in our scores. And we also have seen ways we can improve and what we consistently perform well in. We meet quarterly and review our results. We track our progress and provide imaging education. So when we first started utilizing this completeness checklist, we realized that we weren't consistently demonstrating the mitral valve on FOSS. The first quarter was only included in 56% of studies. We were able to increase it to 90%. And one of the images we added to our protocol was a left SVC sweep. And these audits helped us realize early on that we needed education on how to perform this correctly. So following education, our compliance has risen to 90%. And we have not missed one left SVC on a patient going to surgery for more than a year now. So moving on to diagnostic accuracy. So we flag studies that have a potential discrepancy with another imaging modality or surgical findings. Initially, we tried to capture this through a REDCap survey, but our staff found it really difficult to take the time to enter this data. So we knew we needed to move to an automated process that was built into our workflow. So we created a mandatory field in the reporting system for all the pre- and post-op TE reports. So the reader must note whether or not a discrepancy was found. And we also created a mandatory field in the post-op report that our surgeons complete. So they must indicate if there were any discrepancies between the pre-op imaging and their intraoperative findings. So these two sources ensure that we capture 100% of the data. So flagged cases are reviewed by the team monthly. They're categorized, and we select key cases for teaching points to share in our quarterly QI meetings. And this process has been very beneficial for us. We've made changes to our protocol because of things we found. For example, we added a high right peristernal view to our initial protocol to assess for anomalous pulmonary venous return to the SVC. And this run chart shows our discrepancy data. The calendar quarters are here on the x-axis, and the rate of diagnostic errors are here on the y-axis. This orange line represents the overall error rate, and the blue line indicates clinically significant errors, which are defined as moderate or above. And as you can see, our process has resulted in a decrease in our overall errors, and the clinically significant errors are infrequent. So being timely means providing healthcare services as soon as possible. To ensure this, we began working on a project to improve our efficiency in completing our inpatient studies. So we have a team of faculty and second-year fellows collaborating with the sonographers to achieve this aim. And we use data from our electronic medical record and reporting system to plan our interventions. So we learned early on that this was going to be a very challenging project. We are a very high volume center, and our sonographers cover multiple towers here in the medical center. And the fellows did extensive work to delineate the complexity of our inpatient echo process. And this key driver diagram demonstrates the massive scope of this project. So the three main drivers identified included improving communication, reduction in inefficient processes, and conducting education efforts. The team has also come up with secondary drivers and ideas for potential interventions that aim to tackle things like the echo ordering process, as well as our internal workflow. So we use the QI method of plan, do, study, act to test the changes that are implemented. We used process mapping and swim lane diagrams to understand our workflow better. And it became clear that echoes were not evenly spaced throughout the day. We had significant batching resulting in these peak and lull periods for the reader. So one intervention was to limit the number of studies picked up by our early sonographers to just 1 or 2 so that the reports would be ready to read by 9 o'clock a.m. And we also added a flow coordinator who could better prioritize the studies and dispatch the sonographers accordingly. And we provided education to the team. So we continue to track our progress, though. So far, we haven't really made significant headway. We're hopeful that we're going to see significant improvement with our next intervention, which is a modification of the echo order when it's placed into the electronic medical record. And this will help us better triage studies based on urgency. So this is still a work in progress. And lastly, I wanted to briefly touch on another project we've been working on, and it's our 2D ejection fraction by Bullitt and Simpson's biplane methods. We had a lot of new sonographers join the team last year, and we noticed high variability in how we were performing these measurements. So we launched an effort to standardize our process and minimize the variability. And this relied heavily on education. So this timeline shows our progress over the last year. We started with some didactic teaching and then followed with auditing and individual feedback. And we continue to see significant improvement in our team's performance. Oops, sorry. Lastly, I just wanted to say that with any QI project, it really helps to automate your data collection and engage as many people as possible. We face the same struggles as any other lab, making time for these projects while keeping up with high patient volumes. It's taken us a while to get where we are, and here are just some of the members of our amazing, hardworking team. Thank you.
Thank you very much, Alison. That was really a speed read through of the QI work you're doing, and to be applauded that your lab has collected around some really amazing stuff. I was looking at your key driver diagram, and I'm impressed that anything that any lab could ever want or we as a field should achieve is actually in your specific aim. So no wonder it's been a tough one to get off. Thank you very much, Alison. I would like to now introduce my friend and dear colleague, Dr. Shobha Natarajan. Dr. Natarajan is an associate professor in the University of Pennsylvania and is the director of quality improvement in Children's Hospital of Philadelphia. There, as part of her QI directorship, she actually leads quite a large team of quality improvement advisors, data analysts, and of course QI thinkers, which is all of you who've joined this call. I'll let Shobha take it away, and then we'll collect for questions later on. Thank you, Shobha.
Thanks, everybody. And Alison, that was a great talk and really a great outline of what needs to happen in an echo lab to truly engage in quality improvement. And my talk looks at it from sort of a multi-center perspective. This talk really is the beginnings of a multi-center quality improvement project to decrease preoperative imaging errors prior to surgical repair of congenital heart defects, and really speaks to a lot of the things that you were talking about. Next slide. So echocardiography is currently the mainstay for the diagnosis of congenital heart defects requiring surgical repair. Errors in this imaging prior to surgical repair, called diagnostic errors, can have a significant impact on postoperative outcomes. And preoperative echo error rates can range from anywhere from 3 to 30% in the published literature. And single center improvement efforts to reduce these errors really have had variable sustained success. And I use the word sustained very seriously because that's really what the issue is in a lot of these QI projects. So our aims are to outline the design of a multi-center QI project under the auspices of the Echo Lab Collaborative of the Society of Pediatric Echo. To determine the baseline diagnostic error rate for preoperative echo in the current era, to learn about anatomic areas, preventability, and clinical impact of diagnostic errors, and to evaluate patient level and system level factors that increase diagnostic errors. Next slide. In terms of the methods, the Children's Hospital of Philadelphia executed data use agreements for participating centers, and a REDCap tool from CHOP collected patient data from all centers after local IRB approval. There were monthly virtual meetings with all participating centers through SOAP, which really was made to refine the REDCap tool, review baseline data, and delve deep into the systems issues that can lead to diagnostic errors, which is really the define and diagnose phases of QI methodology. Next slide. In terms of definitions, a diagnostic error is a missed preoperative finding that was correctly identified in the operating room or within 14 days of surgery. Preventable errors were ones that where the correct diagnosis is expected on the preoperative echo. Possibly preventable errors were ones where correct diagnosis is possible with optimal conditions, and unpreventable errors were ones beyond the capability of echo. In terms of clinical impact, errors with minor impact resulted in no significant change in patient course. Those with moderate impact resulted in a change in course, but without adverse event. And errors with severe impact had an adverse event or an unplanned reintervention. Next slide. These were the diagnoses in our initial pilot cohort. So these were all relatively straightforward diagnoses, and single ventricle heart defects and complex two ventricle diagnoses were excluded at this time. Next slide. So in terms of the number of consecutive patients entered per center from May 1st to March 31st, 2022, there were of total 1,316 patients that were enrolled. The volume at each center was variable depending on how large the center was. And there are 3 centers that have incomplete data sets that I'm hoping to get completed by the end of this month. Next slide. The baseline monthly rate of preoperative diagnostic errors across all centers from the same time period. So a diagnostic error rate is the number of patients with diagnostic errors over the number of index surgery times 100. And you could see from this graph, if you move forward, there were 97 unique patients that had errors. And so the mean error rate over time was 7.5%. And while there was some month-to-month variability in this graph, the rate was relatively stable over the 11-month time period. Next slide. VSDs, AV valve anomalies, coronary artery anomalies, and aortic valve anomalies were the top anatomic areas of errors. Next slide. Most of the errors were preventable. Next slide. And while the most significant clinical impact was minor, there was an important cohort of patients that had moderate to severe clinical impact of their errors. Next slide. And center-specific error rates varied quite a bit, and we are just figuring out what this is related to, but it varies from 0% to 21% across 14 echo labs. So conclusions from this is that we have successfully completed the baseline data collection for the first multi-center initiative to address diagnostic errors prior to heart surgery. The baseline diagnostic error rate was 7.5% in over 1,300 patients from 14 echo labs across the country. The top anatomic errors were VSDs, particularly in the setting of a large VSD, AV valve anomalies in the setting of patients with AV canal defects, and coronary artery anomalies. Most errors were preventable or possibly preventable, and 19 or 25% of errors had a moderate to severe clinical impact. Next slide. So clinical implications indicate that changes in the systems of care may possibly impact the diagnostic evaluation and the preoperative discussion prior to surgical repair, and hopefully reduce diagnostic errors. So future directions include submitting a manuscript outlining the process by which we have created this initiative and the analysis of the baseline data to highlight patient and system-specific factors that can lead to increased errors. We're going to define a bundle of change ideas that can be implemented at individual centers to decrease error rates over time, like sedated echo protocols, echo report templates with discrete data elements, multi-modality imaging protocols, surgical discussion templates, etc. And we are then going to have a second round of data collection in REDCap to see if these changes result in decreased error rates. And these are iterative PDSA cycles. It really has taken a village even to do this amount of baseline data work. So I really want to thank the echo labs that have participated in this and have been willing to take the time to collect the data and be a part of the calls. And finally, I also want to thank the Society of Pediatric Echocardiography for giving us the opportunity to open up an initiative like this one. Thank you so much.
Thanks so much, Shobha. That was an amazing quick view of all the hard work that you have been spearheading from many of our labs, and it's huge getting 1,000 data points from 14 of our labs, and so that's a lot of work. Both of these topics are open for discussion. Please put in your questions in the chat or unmute if you can, and tell us what you're thinking.
You can go first. Allison and Shobha, those are great presentations. Thank you. I have a question for Allison. How do you onboard new sonographers or junior sonographers or anyone new to your system? Is there a structure you follow? Do you do one-on-ones or you just incorporate them into your educational sessions? I would love to hear that.
I wish our education coordinator was here to answer those questions, but I have been involved in that. So we, of course, like any hospital, we have checklists that things that are hospital-wide plus department-wide that they have to achieve as they move through orientation. and we have echo specific ones. One thing that we like to do before we turn a sonographer loose, like on portables, is we will have them print 25 consecutive preliminary reports, and we will compare those to the final read just to see where their understanding is for describing the congenital heart disease that they're scanning. And we find that really beneficial for us and for them, just to kind of gauge where they are. But our education coordinator, she meets with them on a regular basis just to review their progress. And we're so thrilled with our new sonographers. They're just so fired up and excited and just motivating the rest of us. So, but that's a big part of our process.
That sounds great. Thank you.
Allison, just something I wanted to comment on, which I really love, and I think a lot of the education coordinators and those that are out there listening right now, I think one thing that actually made a difference in our lab also was that everyone got quantifiable data. It was a lot easier to give feedback when we can actually give numbers to them. And, in 2022, I think I told our lab that I had reviewed some 1,500 echoes just to kind of get a baseline of what everyone was doing. But once everyone got the numbers, it really put a picture to what we were looking for. And within months, everything all the quality shot up, and it's just been fantastic. So if you guys are trying to figure out how to train or just get a hold of the quality, I think that quantifying whatever you can is the best way to do it. So I really like seeing that.
Yeah, particularly with our ejection fraction project, like their individual feedback came with like arrows to where it should have been traced, where the mitral valve annulus should have been included, and that's why we've seen such significant progress there.
And we have we have a system where everything is sort of in dashboards and in other sort of virtual places and on the computer, and very discrete data fields like you probably do in Texas, and others do as well. And I think that also keeps the amount of work low as well. And I think that's really important too for QI, because we have such competing priorities with everything else that we have to do as cardiologists and as human beings. I think it's really worthwhile to have that sort of automated data collection for anything that we do. So that's great.
There is one question from Shubi about imaging protocols, how they are disseminated and where they are housed and how often they are rediscussed. Would you guys like to speak about that?
I mean, in our lab, all our protocols, the ones that we have protocols for, are kept online, and some of them are also kept on the machine so that it reminds the sonographers what needs to be done, especially some of the focus protocols, like the focus pulmonary hypertension protocols or the heart failure protocols. But they are kept on the Echo Lab intranet, just within the hospital intranet. So they're easy to get hold of.
In our lab, we have a shared Teams folder for all the sonographers where we keep didactic lectures and protocols, and we have open access to that for everyone.
I think it's something to consider now that we have Teams and we're using it so much more. Might be another good place to keep everything.
I have to say, it seems to me that it might be worthwhile. There's probably on this call, like maybe something like 30 centers, which means there are 30 times at least 6 protocols. And that's about collaborative learning. One of the things that both your centers are doing and leading is trying to find out the gold standard within the center and within different centers. And potentially, to Shubi's point, is wouldn't that be wonderful if we could actually share all of our protocols, and then we could pick which one is doable where, and maybe have a standard way of doing everything all the time.
I think that's a great idea. I think in cardiology, it seems like echo folks are more collaborative than many other subspecialties. And I think it would be a great idea to share protocols across centers.
Yes, we are hoping to do it actually within the SOAP website, hopefully.
Great.
Yeah. And for our lab, we go back to them as we think about them, almost like spring cleaning. We say, okay, you know, there are a few protocols that need some adjustment. We go back, we discuss it within ourselves, within faculty and sonographers. So it's not as live as you would think. So not everyone can go in and make changes, but after a discussion, we edit it and we circulate it and put it in the box. So it requires some discussion before we make changes. And then this came up. Yeah, go ahead.
And Sarah, so this is a question for Allison. Allison, you mentioned something about modifying the echo request and modifying the echo order. I'm curious to hear a little bit more about that, because at least what I've been told is that one can't modify the verbiage of the ordering provider's request because you just can't, for whatever be the coding, billing, legality of it. So I'm curious to hear how you do it, and if anybody has an idea about how to capture that feasibility there and make it work for us.
So for us, in our electronic medical record, we just had to submit a request with IS to try and just update and put more language into the echo order that describes, you know, urgency, with clarifications where what clarifies a stat or what quantifies ASAP, because we get inundated with ASAP and stat orders that don't constitute that you know, urgency. So we're wanting that built into the order, so the provider putting in that order has to specify if it needs to be done today, can it possibly be done the next day if the volume is really high. And it's taken a really long time for that to go into be implemented, and I'm not exactly sure why, but we're hoping that we're going to see improvement with that. But it was, I think from my understanding, it was a ticket with our, you know, IT team for our electronic medical record system.
I can vouch that it's really hard to do IT work in a large, and yeah. But it gets done, I think. I mean, it takes time, but you can alter the echo orders.
And Shubi brought up a great point about anonymizing. When you guys do your QI reviews, do you anonymize everything?
Yeah. Part of
here we don't. It's not something that's been brought up as an idea. Currently, I'm doing all of the auditing. And on our last review, or for last quarter, we had like 42 sonographers system-wide. So I can see where it could be a bias, and that's a good point, you know, to anonymize them, but it's not something we've discussed here not yet.
And I think that also comes up on the reputation of the reviewer. When you have forms and checklists and things that are very objective, it becomes very hard for someone to say that you had an opinion about the person's echo, as opposed to clearly showing, you know, you missed 1, 2, 3. And just like you have that point system, that's why it works, not anonymizing it, because you just have a great scale and it doesn't matter who's done it. You're just looking at the echo.
True. It's either the view was captured or it wasn't, you know.
For us, we always start our QI with like, oh, this don't feel offended. This is all for learning, and this hope this is don't take anything personally. And there are some other images that you can't really studies that you can't really anonymize, because you know who did it, and you know that this in our field, it's really like a very complex congenital heart disease. It's truly non-anonymizable. That's why in some institutions won't let us post on social media because the diagnosis itself is fine, is what they say. So I think you can't truly anonymize it so hard.
So then I must say we have participation from Pakistan. Dr. Mohsin has joined us and has shared. So everybody must read her paper also and their work in Pakistan.
Thanks, Shazia.
Yes, thank you, Shobhi. So I just wanted to add that we also de-identify our studies because initially when we started this project, we called our meetings mortality and morbidity meetings in ECHO. So we did face some resistance from people because it was like kind of getting to what we have like sometimes in surgical M&M, we have a lot of leg pulling sometimes instead of improvement. And this was making people add addendum or change the report. Then we de-identified, we call them quality audit meetings, and before each meeting we would put a disclaimer that this is just to improve the program, the quality of the program and the quality of the and the outcome of our patients, and this is not personal, and this was a disclaimer in slide in each of the presentation. And this I learned from Stanford. When I went to Stanford, they used to run their meetings like this and they had this slide there. So this really helped, and de-identification helped. And I, as an Echo Lab director, was the major person who was reading the Echo. So major diagnostic errors were of course mine as well. So I put myself in the front and my studies, and this kind of removed that bias. And people started reporting there because we don't have an automatic system where we can report this electronically. So people would come and report themselves that, okay, this is the error that they found from the previous study. Like, for example, if they missed a left subclavian vein and they found it in the next study, they would come and report themselves.
Yeah, so in our group meetings where we meet together, any images are anonymized. But I guess I misunderstood. I thought like when I review their studies, they're not de-identified for me. I know who did the study when I'm going through the studies.
All right. Well, thank you, everyone. This has been great speed event again, just to jumpstart our new year. And just want to let you know that our next speed event will be sponsored by the Career Development Subcommittee, and it will be a discussion on program building. So this session will introduce the upcoming series of informal sessions from the Career Development Subcommittee to encourage greater dialogue amongst our SOAP members about all aspects of career development, including mentorship and coaching. So stay tuned for that. It's going to be on February 28th, again, 4th Tuesdays of every month. And another exciting thing is starting on February, we can now offer CMEs to SOAP members. So if you attend our SOAP Speed series, you will receive CME credit. So it's going to be 30 minutes. So it's going to be half a CME, 0.5 CME credits. So remember, on all these CME credits for the whole year, if you attend the whole year, you will get 6 CMEs in addition. So that's exciting. Now I would like to pass on to Shubi to talk about our membership.
Thank you so much, and thank you so much to the speakers, the moderators, and to the membership. As you can see, we have like significant engagement, and we would like you to spread the word and increase membership and attendance to SOAP. Please reach out to Tara if you need more details, but you can either have individual membership or institutional sponsorship. And institutional sponsorship will allow for enrollment of physicians and sonographers. So do encourage your institutions to sponsor. And if you're a platinum sponsor, you could also be involved in, deciding and be part of one of these education subcommittee offerings or the mentorship offerings. And then, so with that, I just wanted to say, please reach out to us for questions. Please reach out to us. And thank you so much.
Bye, everyone.
Bye. Thank you for attending today. See you next month.
Bye, guys.
See you next month.
Thank you.
Take care.
That was a great turnout.
That was great. Thank you so much, Neha and Jen.
Oh, you're welcome. That was good. That was
No,
awesome.
thank you, Shobha. Thank you, Allison, and thank you, our speakers.
Fantastic.
Artie,
This is the
that was
first
wonderful.
time. Artie said I go first, but we've had speakers like 10 minutes.
Shubi, you're kind of cutting out.
This was fantastic.
Oh.
Can you hear me now?
Yeah, you were frozen for a sec. For me, I'm not sure if it was from.
No, I was just saying that it was beautiful. Everybody stuck to their time. Everybody stuck to the script, except I forgot. You can. I'm aging.
It's okay.
You're like 2 seconds older than me, so don't even.
I wish I was only 2 seconds older than you.
You're younger than me.
Old. But Shobha, you were great. Thank you so much. And Allison was fantastic. Thank you.
This was a great topic to kick off the year. I think that I felt like I wanted to scream at the screen because everything that Allison had presented, I'm like, I'm doing that. That's new. We're doing that now too. So it's great. It's great to see that other people are doing, and I'm not off in left field when we're doing something like that. So it's great. Love it. Love this new year starting.
Yes.
And thank you.
Thank you. We'll talk in a few weeks, I guess.
Thank you, Tara.
Yeah.
You're welcome. Thank you, everybody.
Thank you.
Bye.